Our next topic for discussion is going to be herniated nucleus pulposus, otherwise known as a slipped disc. And before we start to talk about that, I thought we would review a little bit of anatomy and physiology. So if we take a look at the picture, you note that here is your backbone, and you've got all these vertebrae. Between each vertebrae is a cushion, a shock absorber, if you will. That's your disc. It's between the vertebrae, and that keeps the bones from rubbing against each other. As I said, I just call these shock absorbers, and that pretty well describes what they do. Now, coming out at each of these vertebrae level are spinal nerves. I've just drawn in a couple of them here, but there are spinal nerves at each of these vertebrae. Let's look and see what happens when you have slipped discs. Now this picture shows us normal. So here is your spinal column, and here's the nerves that come out. And so those are your spinal nerves. And here is your disc. Now if we look at this picture, look how this gelatinous disc has squished out, and it's pushing on a spinal nerve. I often think of it as being kind of like a jelly sandwich. So you've got the vertebrae being each of the slices of bread, and the jelly in between is this gelatinous mess like your disc. And when you have a jelly sandwich, you'd like all the jelly to stay between the slices of bread. And sometimes it squishes out. And that's what's going on with a slipped disc. It squishes out and puts pressure on the spinal nerve. This next picture shows a sideways view of it. You see that disc squishing out. So it's squished out from between the vertebrae and presses on a spinal nerve. And that's what's going on with a slipped disc. Now wherever it is, whichever nerves, that's where your pain is. So if the disc is in the cervical area, you're going to get shoulder and arm pain. If it's in the lumbar area, you will be getting low back and leg pain. And this is pretty severe pain. This is nerve pain, which is really severe pain. Now typically when someone has a slipped disc, they go to the doctor, they are complaining of severe pain, and the doctor gives them some muscle relaxants, some painkillers, maybe recommends traction or heat, or maybe some physical therapy to open up the spaces. And we'll say, come back in about 4 weeks and let me see what's going on. And sometimes it gets better. Sometimes it will get better with this kind of regimen. Some patients will even go and have epidural nerve blocks. The pain is so severe with this. Surgery is a kind of a last resort for slipped discs. And so typically patients have had an episode of terrible pain and it got better. And then a few weeks, months, years later, it happens again. Now, particularly with things like in the lumbar region, sometimes it's come on by when people do something rather silly, like moving refrigerators without help, and they're using poor body mechanics. Other times, they bend over to tie their shoes, and it kind of pops out. So it's hard to tell exactly what's going to be causing this slipped disc. But typically the patient comes and has had 2 or 3 or 4 episodes of pain. And it finally gets to the point where the pain can't be relieved. It's just unbearable. Or they're beginning to get permanent damage. It's pressing so long on nerves that they're beginning to lose nerve function. And this is when surgery is done. So it's not usually the first choice. And the reason is it's not always successful. And there are side effects to the surgery. So now let's talk about someone who is having surgery for this. So we're going to talk about a patient who's having cervical surgery. So they've had a cervical slipped disc. So they've had severe shoulder and arm pain. Now the procedures, there are several different procedures, and we won't go through all the differences of those, but they are having either a cervical discectomy where they remove the entire disc and do a bone fusion, or maybe a laminectomy where they remove the protruding part. I want you to think about a patient who has just had a cervical discectomy or a laminectomy. And you are working, this patient has just come back from post-anesthesia care unit, so they've recovered from the surgery. They're coming back to your nursing care unit. What position will you put this patient in? Remember, they have just had a cervical discectomy or laminectomy. You want to put them into a low Fowler's probably position. So you want their head up about 20 or 30 degrees head elevation. Now let's think about why. The cervical region is up here in this neck region, and the incision has either been in the back of the neck, or sometimes they go from the front, kind of push away the thyroid and get back in that way. But what else is in this neck region? The airway. And whenever you have surgery, you have swelling. And you want to prevent edema in this region. So you want to put the patient's head up to reduce the amount of swelling. Whenever the patient turns or moves, you will have them log roll. So you will have them move their neck, keep their neck stiff and straight as they move. You don't want them to move their head around when we've just had surgery in that area. They may have a collar on as they come back from that type of surgery. So initially we're going to put them with their head slightly elevated in a low Fowler's 20-30 degrees head elevation. All right, now you are taking care of a patient who has come back from the unit. And in addition to routine vital signs, what else would you assess because of the location of their surgery? You want to assess airway, good. You also want to do upper extremity neuro checks. So you're going to say to the patient, squeeze my hand, move your hand, push my hand away. So, because remember that the arms are innervated in the lower cervical nerves. All right, now you are taking care of a patient who has had a lumbar laminectomy or discectomy. And this patient has finished their time in post-anesthesia care unit, is coming back to your nursing care unit. How would you position this patient when they get back to the unit? This patient will be flat, supine. So for the first few hours, they're going to be supine. Now, in addition to routine vital signs, what would you assess because of the location of the surgery? So you would want to assess lower extremity neuro checks, and we're also going to be very concerned about bowel and bladder function, because that's what's innervated in that lumbosacral area. So it's interesting, you can plan nursing care simply by knowing the location and function of the structures that are affected.